So we'll treat these 3 teeth primarily. I'm seeing about 4 millimeters on the canine with no attached gingiva. There's also no attached gingiva, as you can see, a little frenal pull coming near the margin on the first premolar, and maybe a millimeter of attached gingiva on the second premolar. Also, if we come forward, there's very slight recession on the facial of the lateral incisor, but a little bit more proximally. I don't think we can do much with that, but because there's significant recession on the canine, I'll extend over and include the lateral and see if we can support that papilla a little bit. You might be able to see that there's a little depression right in this region between the lateral incisor and the central, and a lack of fill. But also there's a little concavity here. You can see a big change of direction of the enamel and the root. So there's a possibility of bonding that a little bit and improving that shape on the mesial aspect. So that's where that little change of direction occurs. And there's a little concavity right in that region. So there's a possibility that that can be improved with bonding on the mesial aspect. But we'll see what we find with the root surfaces. It's hard to tell if there's some new bonding. It feels like there might be new bonding on this lateral as well. So we'll look at that. That's recent, and it's a little bit hard to feel a difference. But as I come down here, down this enamel, I seem to get a little convexity there, suggestive of restoration. There may be something on the canine, a little bit of a suggestion of change of contour there. We'll check that. Definitely on the premolar. So we'll floss first to clean the area. And actually, teeth are very clean. That's nice. But we still go through every site and freshen it just to remove any deposits the patient might have missed. I picked up a little bit on the distal of this premolar. And a little bit on the molar as well. I think you all know how to floss. I'm not worried about visibility on all of this so much, but just to show that it's important to clean the site well prior to doing the intrasulcular approach. We'll start this intrasulcular incision at the lateral incisor. And I will include the distal of the central. And I don't need to advance the margin here much on the lateral, so I don't know that we need to elevate a lot of the central, but I will go to the middle of that central incisor at least. And again, our focus is more on the canine. But if I can improve this region at the lateral while I'm there, that would be nice for the patient. So we'll continue this intrasulcular separation process around each tooth, facially and proximally, and being cautious where it's thin on the facial aspect of the canine. That's the thinnest area. And this instrument's nice because it's a very thin instrument and narrow. So it allows us to slide into that sulcus with minimal displacement of the tissue. So continuing now with the second premolar. And of course, you didn't see me do the infiltration, but you probably guessed that I did. I did infiltration with 3% lidocaine with epinephrine 1 to 100,000. We may have a little bit of a delicate papilla attachment in between the second premolar and the molar. So we'll start with the straight elevator. Using the curved end, I call it the straight because we have a right angle elevator that I didn't show you yet. It's a new instrument that I'll show you in a moment for our posterior areas. But I'll elevate this papillary region to take the tension off of the margin of the delicate tissue. I may block your view a little bit from now and then, but trying to show you everything. But there's a lot of bound down tissue here on the lateral, and I must mobilize all of that in order to be able to advance the margin of the canine. And once again, I'm including the lateral because I think I can make it a little bit better. And as long as we're in this region, we should try. And that means I need to elevate the attached gingiva at the central incisor as well. So if you can see what I'm doing, I can enter the sulcus. I think that's a good view to show that with the curve level with the tooth or adjacent to the tooth, and then I can swing out a little bit to get under that tissue and elevate it. And I can do that without stretching the margin. Now, the areas you have risk of perforation are right at the mucogingival junction and at any undercuts. And you always have undercuts, mesial and distal to canines. So we'll be careful in that region and every place else too. There's a little irregularity in tooth position and alveolar form here at the central lateral too, because there's a little excessive space between the lateral and the central. And I always worry about the papilla between the canine and the lateral incisor. It seems like it's commonly a little bit weak as well. So I want to work this slowly until I get apical to the mucogingival junction. And there's just a little difficulty right here because of that depression. So I'll just work it a little bit more slowly, working from the lateral, from the central toward the lateral. I'm going to go in with a straight in here for just a moment and see if I can negotiate that better. And I think if I mobilize this, I can come back with the curved in facing downward and make some progress in this region. I'm not quite there, but close. So let me see what I can do on the canine. I'm just trying to work that attached tissue. There's a large zone, once again, of attached tissue in the interdental region and an undercut. So I'm going to turn now with the curve facing downward and see if I can engage that undercut. And you'll see I'm working pretty far under that tissue down to about that level at the canine to get some relaxation of that tissue once again. Let's see if I can come now from the lateral incisor sulcus into that undercut and swing over toward the central. And this is the hardest area to mobilize. It's the area with the greatest bound down tissue. In fact, whenever you're dealing with minimal recession or recession in the presence of significant attached gingiva, actually the dissection process is more difficult. I think we've got it pretty well loosened in that region. Really tight tissue. Hardest part, again, in the area with the least problem. So I want to be careful with this papilla, distal to the canine too. In fact, all the papillae. Just work your way slowly through these regions. We don't have as much attached tissue here, so it's a little bit easier. So I've worked a good bit of the premolar region. I'm working the molar a little bit now, mobilizing the tissue distal to the last tooth. There's a little bit of recession on that molar, so we probably can advance it. And you can see this papilla move a lot. It's a little bit fibrotic, had been swollen in the past. Probably a weak papilla, so be cautious with it as well. And the idea is to get apical to the mucogenital junction. And sometimes we have a little bit of access difficulty in the posterior region, and we have this right angle elevator that we can use, and it's particularly useful at the mesial aspect of teeth. So I can get under that papilla with the right angle, and it works really nicely. So I'm showing you that again at the papilla between the premolars. That's pretty good separation. I'm going to go turn it the other direction, and actually I can also get under this papilla distal to the premolar. So between the molar and the premolar, just two different ways to reach that, and do a little bit of the dissection at the molar region. So we're in pretty good shape with this blunt elevation. And just want to make sure that the facial aspect of this canine is good. I want to use a curette now and inspect these roots, see if I can tell what's going on with them a little bit better. Don't know that there's a restoration on that lateral. I'm just going to root plane this and see what I can tell about it. With the new restorative materials, it's difficult to tell where restorations are, and I felt there was a little convexity here indicating a restoration, but I can't really feel it with a curette. So I'm just doing root prep, and if there's something on there, it's pretty thin. And we're on the K9 now, reclaiming that area. And I want to freshen this root. There's no depth here. And once again, just making sure there's no bonded restoration present. And we just want a uniform root surface that's freshened primarily. We're doing good there. Now on this premolar, I think we have a restoration present. We'll see what we find here. And I could use the Varios to remove it, but I want to be sure what I'm dealing with, and the curette's working fine. This is a younger, good 7/8 curette that has been well prepared by Shannon. That sure did seem like it was a restoration, but it was really thin. And younger good curette is really a great curette for doing this root prep. And it doesn't look like we need the Varios. I'm just checking these proximal margins of the root, because that's where you'll find sharp edges, as well as, of course, the apical margin. But we look good. There's a restoration that I don't want to remove on the second premolar. And it's been restored to the site that it should have been, and that's just to a new CEJ. So I'm checking those sharp angles, proximal angles, and gingival margin. To bevel any sharp edges and smooth those roots. All right, so I think we have good root preparation. So our next step is application of EDTA. So we use 70% EDTA, apply it with a cotton tip applicator for 30 to 60 seconds, and just rubbing the root surfaces. And this will remove any smear layer. I think it helps killing bacteria in the area as well. And at this point, we've only done blunt reflection, so I don't think we're creating any issues. It shouldn't harm the blood supply, so we should be good with that. If we're using citric acid or tetracycline, I think there's a little bit of risk of injuring the vasculature but here there's not. All right, so now we will rinse this with normal saline. I'm going to separate the patella from the intradental crest. And the most difficult one is going to be this one between the central and the lateral. So I'm going to come into the sulcus, the central, and see if I can slowly work my way to that crest, because I don't think I got a real complete elevation in this region. So this can actually help you with a little bit of the blunt reflection in a hard to reach area. Now I'm under the papilla. Can you see the papilla moving? So I should have separated that papilla from the crest. And so what I did is I went in that sulcus, I went underneath and came back, tried to go touch the lateral. So now we'll go into the lateral sulcus just because it's such a wide papilla. If I can slip into that lateral sulcus, and under the papilla, free that facial part. And I'm going to go back into the sulcus of the central. Make sure to touch that lateral incisor too. I want to be gentle with this papilla because I don't trust its attachment. It has been displaced now. Same thing here. This is even weaker papilla. And I'm having a little trouble from that direction, so I'll try the other direction. That is more successful. So we have mobility of that papilla. So this one with the blunted tip worries me again because it's very weak. And I think you can see that weakness. I should have it detached now. And we have pretty good movement. And now I'm certain of the last papilla. So even without the sharp dissection, we have pretty good movement in this posterior region. I think you can see that tissue advancing. The rest of it's not moving much. So we'll finish that preparation in a moment. But what I will do now is show you the measurement and trimming of the graft, because Shannon usually trims the graft, but I will do it so you can see it. And I'm going to measure, I want to extend to the mesial line angle of the molar. So this is a 36811 probe. So that's 11 millimeters. That's 22, gets me to about that point. And 33 will get me just past the line angle. I'm going to say 35. I'm going to add a couple of millimeters. So I'm going to do a 35 millimeter graft. And we'll have a vertical dimension of about 8 millimeters on an upper. You see the kit that I described, and you see our two rinses. We had a normal saline rinse followed by normal saline with 100 milligrams of minocycline. So our graft is sitting in that one at this point. It's been in there plenty of time. So I'll slip that graft out. Looking at the graft now, you see a nice thickness, and we see two different sides. And if you look really carefully, this is more of like, I call it a suede look. On one side, it's a little slicker on the other. So this is the basement membrane side. That's the connective tissue side. And this is a great graft because it goes almost completely across the gauze. In fact, it does completely across. So they're larger than what they say. And I'm using a new little carving platter from Hugh Freedy. 5, 10, 15, 20, 25, 30, 35 sold. So we can cut that at the 35 mark. And then we need 8 millimeters. So I will come with my 368 11 probe. And now I have a graft that is 35 by 8 millimeters. And I have it on top of a gauze at the same time. And I have a gauze backing I don't want on the graft. And we have a 35 by 8 millimeter graft. I'll put that back in the tetracycline for just a moment, and then blot that with the gauze, and then transfer it to the PRP. So this is the PRP solution, platelet-rich plasma. We'll put the graft in there. It'll be in there for at least 2 minutes. So the next part of the preparation will be done with the modified ore band that you can see here. And I think you see the rounded tip, and that's the dome side, and then that's the flat side. So you have a pretty good idea of what that looks like. And I can stretch the cheek up, slide into the sulcus, and start the extension of the pouch apically, and staying in contact with the alveolus as I do that. This is a trickier area because it's really tight. I don't really need to mobilize that central incisor much, but I would like to get under this papilla. And that's not complete, but I'll come back and finish that in a moment. So I'm coming in at this angle. And working my way toward the distal. I'm going to slip back out, get another entry point here. And just staying in contact with alveolus as I do this. I'll go back to this lateral and see if I like what I have up there. Getting better. I'm not totally satisfied with this area right in here, but I can't reach it just yet. So we'll work on that in a moment. Better? So moving slowly. And staying in contact with the alveolus. I may block your view, I don't know. And of course back, just retrace. I felt a little catch there that I got loose. So there may be just one little strand every now and then that blocks you. There's one here too. Maybe more than one. And I'll see if I can reach this area better now. I like the lateral area, but just a little bit uncertain there. So I'm going to use the curette and check that. So I'm going to enter this pouch with ease. And just check that area. I think it's mostly a contour. There's a little strand right there. But it was mostly, I think, contour issue. And you can check the pouch this way too. You can go in with a curette and just feel that it's patent all the way, that there's no little tags that are catching. And it seems very good. My only concern is up here. I'll just check this direction too. I think we're good. I think it's just there's a bump there that may help me. And we can see that I can advance that. And I can advance all of this. Everything moves coronally rather easily. So our next step is to insert and suture the graft, and we'll be finished. And now we'll insert the graft, so remove it from the PRP, and we'll place it with the basement membrane surface facing outward. And insert it through the canine opening. It's a delicate opening, but papillae are delicate everywhere, so there's not a better option. Turn to your left for me. Can you see that okay? I'm good. Can you see it okay?
Yes.
So get that one corner started, swing it, get the other corner under. Watch that in for me. It's going to want to flip out. Shannon is watching this far end that might want to flip down because this graft sometimes wants to go in vertically. The times it might not is if you have an area of significant recession. Because there's the graft up here. I'm going to nudge it back toward the back. Pull it to place, and you can slip that out now. We don't need that gauze. And just about to the point where I can go under and back toward the central. And this is where we see the graft at the lateral incisor, so we know where that end is. And we see it at the canine, of course. We see it at this premolar. And it was not quite straight at the posterior because I could see it through the tissue. But I want to see it at the premolar. And I'm not sure I can show it to you, but I'll try. Yeah, you see it right there. Blot that and see if that shows. Blot that one more time. There, that got it, I think. So there's the graft. So it's well positioned. We know it's under this papilla. And I'm going to keep it exposed at this end for just a little bit. And we, as you recall, we're not really treating the central and lateral, not our concern. It's these posterior teeth when we have them in good shape. So I'm going to start the suture at the most posterior position. And Shannon will help me keep the graft in place. And we'll just push it down just a little. And it's coming out where I don't want it. Now we have it where I do. That needle can turn on you, and it turned a little bit. So we're at the distal root line angle of the premolar. So I go through the embrasure. And around that premolar back to the facial. Shannon is passing it back using the little pickups. Draw that slowly so it doesn't tie a knot in itself, and leave a little bit of a long tail. Shannon's responsibility is to watch that tail. And then I'll go under this papilla. Pretty easily done. And engage the tissue and graft at the distal of the first premolar. And if you'll notice, I'm grabbing the needle in the middle, trying to get that level with the camera. Pretty much in the middle. Shannon's pulling the suture back out of the way so I don't cut it. And I want to be sure we're good with that. That and draw that suture down. I'm not pulling it tight yet because I don't need to yet, but I will shortly. Things are looking pretty good. Snug that up a little bit. Four millimeters off the margin, through the pouch and the graft at the root line angle. And you saw the needle there for just a second. And now then, I go through the embrasure distal to the canine. This is a sling suture around the canine, of course. So we come around the canine. And if this were a single interrupted suture, I would go through this tissue and come back and tie, but it's a continuous. But at this moment, it's around the canine, moving anteriorly to the lateral incisor. And Shannon wants me to put that graft under the margin so it'll be a little easier for me to get the needle under the papilla. And I'll come under the papilla now. And the papilla that I will have difficulty with is the next one. It's a little depressed and it's wide. So go through the pouch and the graft. Hit that tooth gently and then curve upwards to come out. And now through the embrasure, mesial to the canine or distal to the lateral, going around the lateral now. And I can pull on this now. It doesn't pull the end out because it's built up friction. Now the trick is going to be getting under this papilla and exiting out the central, because the central has no recession. And there's just a little bit of an awkward space here, so we'll see what we're able to do. I have a couple options. You may wonder why I'm doing that. One, to see if I could. And the other is I'm going to try to catch the graft at the distal of the lateral to pull it that way a little bit, maybe get it under that papilla a little bit better. So Shannon's going to pull that, so my positioning is different now. I'm trying to get that graft and not hit the suture and exit out the central sulcus. I think I did that. So that's just to give a little bit more security to the graft in that intradental region. So we'll come around the central, and I won't capture any graft on this next penetration. That's kind of what I talked to you about, making an adjustment to get a little better stability of the graft at the lateral incisor by including the central a little bit, or at least penetrating the graft at the distal aspect of the central incisor. Otherwise, it's just a sling. Now we start back. And I just thought it was difficult getting under the patella the other direction. This can be a little bit more challenging. It wasn't difficult a second ago, so maybe this won't be either. I don't know. We'll see. So we want to come under this patella. You gonna help me? Thank you. Shannon wanted to see if I could do it without her help, but I couldn't. Thank you. But she just depressed that margin just a tiny bit as the suture was starting to, or the needle was starting to show up there. So now I'm going to pull that suture back toward the anterior so that I don't cut that suture. Penetrate through pouch and the graft at the mesial root line angle. And we work our way back to the starting point. Now I look at the suture on the palatal aspect, make sure it's in the sulcus. It should slide into it. And you see what nice root coverage we have on the canine already. Stabilize it a little bit more here in just a second. Shannon helped me with that margin, so you see the importance of the assistant's participation in this procedure. It's really fun doing it, and it's fun achieving something nice for the patient. And it really comes to place. If you just follow the steps, you can get a good outcome. A tiny bit of graft showing, but not much. Tighten that up. There's a little bit of a bunching up here, but because we freed all this tissue, it's not a problem. That'll dissipate. I think things look pretty good so far. Almost finished. Are you frowning because we're almost finished? You want me to keep going? We can do something on some other area if you like. Saw just a little frown. I don't want you to be disappointed. You see how that I've just pulled on that suture a little bit and it's snugged up. And it'll be about 3 millimeters apart. Root line angle, 4 millimeters off the margin, 3 millimeters between suture penetrations, approximately. Papilla's bunching up a little bit here, but it was a funny papilla. A little, almost had a thickened peak to it from previous swelling. Same thing with this next papilla. under the papilla. And can you turn to your left for me some? Good. Still with me, Scott?
Yep.
And that's pulling up nicely on that first premolar, covering the root completely. The papilla looks pretty good. And Shannon has a couple of jobs now. Actually, 3 things. She has to do 3 things with 2 hands. She's going to hold the suture out of the way, the cheek up, and pull that suture in toward the posterior so that I can penetrate at the mesial root line angle. And all I have to do is come over the margin of that restoration, which I bumped into briefly. You'll feel that. And then glide under it, come out the sulcus, go through the embrasure, mesial to the second premolar. Shannon captures that needle, brings the needle into the distal embrasure of the second premolar. I've got it. I just lost it for a second. And all we have to do now is tie. So everything is snug. So we do 3 throws clockwise. Tie that gently. Then 1 counterclockwise. 1 more clockwise. And then leave about a 6mm tail. And that way it wouldn't get too short in the post-op period when they're swelling. Now, somebody said about compressing. What I like to do is just see if there's anything underneath and do just gentle compression. There's really not much required. And our last step is to add PRP at each margin. And we're finished. So that's the completed surgery.